additional money for parking improvements, including technology to help you find available space more quickly, and to buy 8 new electric buses.
This speed camera sits near a school and some homes in Southeast, and WTOP Scott Gelman reports it is getting drivers to slow down.
Sharon Kirschbaum is acting director of D.C.'s Department of Transportation. She's pointing to data from one of them along the 4,000 block of Wheeler Road in Southeast as evidence that the speed cameras are working as intended.
When we first put a speed camera on, we were sending out about 7,500 infractions a month.
A year and a half later, that same camera is finding fewer than 300 infractions a month. But she says the cameras have limitations too. For what she's calling a small group of drivers, a camera or other similar tools may not cause them to change their driving habits.
We are concerned with the number of reckless and aggressive drivers.
Scott Gelman, WTOP News.
Now the top stories we're working on here at WTOP.
Dramatic new developments at UCLA, where police are dismantling a pro-Palestinian encampment on the campus.
Another body of a missing road construction worker has been recovered at the Key Bridge collapse site in Baltimore.
Early in-person voting is now underway this morning in Maryland.
Keep it here. We'll have full details in the minutes ahead.
9:48. Traffic and weather on the 8s, over to Rita Kessler in the traffic center.
Well, let's start out with the delays and problems that we're having on 95 in Virginia. This would be northbound 95 has the delays in Stafford in stretches. You're finding it slow approaching 630 in Stafford, then after 630 headed past 610 Garrisonville Road. The crash now on the right side, that crash involving a truck. Then northbound solid from Lorton into Springfield. This was the left lane getting by the wreck. Southbound 95 slows out of Dale City with work taking a lane, and then approaching and passing the Centerport Parkway with the work on the left side. In Purcellville, Hillsborough Road near Alder School Road, you're under
Senate Committee on Health, Education, Labor, and Pensions will come to order. Today, our committee is going to focus on two extremely important health care issues that must be addressed. First, the major need for more Black, Latino, and Native American doctors and medical professionals. Secondly, the alarming rate of maternal deaths in America that is disproportionately impacting Black, Latino, and Native American women. In the midst of a healthcare system that, in my view, is largely broken and dysfunctional, where we spend almost twice as much per capita on healthcare as the people of any other country, where 85 million Americans today are uninsured or underinsured, and where we don't have enough doctors, nurses, dentists, mental health specialists, or pharmacists, we have another crisis on top of all of that, and that is that problem of lack of medical personnel is especially acute in Black, Latino, and Native American communities, which is the subject of our hearing today. Despite making up almost 14% of our population, just 5% of all doctors in our country are Black, less than 4% of all dentists, and just 6% of all nurses in America are African American. Further, despite making up over 19% of our population, just 6% of doctors and dentists and just 7% of nurses in America are Latino. And we cannot forget the Native American community, which makes up 1.3% of our population, but just 0.3% of all doctors in our country are Native American. So why is this an important issue that we have got to address? Well, the answer is that study after study has shown that when Black, Latino, and Native American patients have access to Black, Latino, and Native American doctors, their health outcomes substantially improve. They are more likely to receive preventative services, they are more satisfied with their care, and they are more likely to live longer and happier lives. In my view, it is unacceptable that life expectancy on average, which is low in America in general, is about 5 years lower for Black Americans and 11 years lower for Native Americans than it is for white Americans. It is unacceptable that Black Americans are more likely to die of heart disease and have the highest rates of cancer of any other group in America. It is not acceptable that Black Americans are more than twice as likely to have diabetes, an issue that we are dealing with right now. Major epidemic in America, twice as high in the Black community than the white community. And one of the most alarming and troubling health disparities in America is the maternal mortality rate, which is the other major focus that we'll be talking about today. In America today, we have the highest maternal mortality rate and the highest infant mortality rate of any other wealthy country on earth. In fact, the maternal mortality rate in America is 19 times higher than Norway, 4 times higher than France. Incredibly, according to the CDC, women in America today are twice as likely to die from childbirth than their mothers. And as bad as this crisis is overall, it is much, much worse for Black women and infants. In America today, Black women are nearly 3 times more likely to die from pregnancy-related complications than their white counterparts. The crisis is also getting significantly worse for Latino women. Between 2019 and 2020, the Latino maternal mortality rate skyrocketed by 44% in just 1 year. Meanwhile, Black infants in America are almost 4 times more likely to die from complications due to lower birth weight than white infants. So the question then becomes, given that reality, what are we going to do about it? How are we going to address what is obviously a major healthcare crisis in America? And that is what we'll be discussing this morning. Just a few things that I think we've got to do. We need to substantially increase the class sizes of historically Black colleges and universities, and we'll be hearing from representatives on one of them today. We need to pass the Black Maternal Health Omnibus Act introduced by Senator Booker and Senator Butler. Senator Butler will be talking about that today. We need to substantially increase funding for the Women's, Infant, and Children's Program. We need to substantially increase funding for the National Health Service Corps. And in my view, we need to cancel student debt and make all public colleges and universities tuition-free so that all people, regardless of background and income, will be able to get the education they need, including going to medical school. And in fact, the good news is that making medical school tuition-free is a growing idea. In fact, 4 medical schools in America, including the New York University School of Medicine, are currently tuition-free, while 5 others have made tuition temporarily free or are offering free tuition to working-class students. So we've got a lot to talk about today, and I look forward to a serious discussion about a serious issue, and I thank our panelists who are here with us. Senator Cassidy?
Thank you, Chair Sanders. This committee has covered the shortages of physicians and other health workers extensively. Shortages hurt the delivery of health care in all communities. My home state, Louisiana, projected to have the 3rd worst shortage of physicians of any state by 2030. We need more doctors, particularly in the underserved areas lacking sufficient health care resources. My practice as a physician was for 25 years in a hospital serving the uninsured and the poorly insured, which is to say Medicaid. So this is something which I have spent my professional life attempting to address. Today, we're going to look specifically at minority doctors and health professionals underrepresented in our healthcare system. For example, African American physicians account for only 8% of all physicians, despite comprising 13.6% of the population. Now, if you're listening carefully, you'll note that my statistics are different than the chair's. His is 5% and mine's 8%. My data is more, he uses the Association of American Medical Colleges 2019 data, and I am using the Bureau of Labor Statistics, which is 2022 data. That's important. 2019, 2022. Government data, a little bit more up to date, a little bit more valid. Maybe there's progress being made. And as we look at something which needs to be addressed, we can also say that if we've gone from 5 to 8%, there may be progress being made, and that is a good thing. But it's interesting to note that this disparity is not felt across all minorities. Asian doctors account for 22% of all physicians, but are only 6.8% of the population. And this is an important nuance as we address the situation. It's also important to note, as the chair notes, that we have a limited number of GME residency slots to train new doctors. And these residency positions are not allocated or dispersed to reflect where underserved communities are. Unfortunately, this topic is under finance jurisdiction, but it's an important context and needs to be considered in any conversation about addressing healthcare workforce shortage. It's kind of a truism that a physician will practice within 100 miles of where she or he does their residency. If the residency spot is not in an underserved area, it's not going to be within that 100 miles. But access to opportunity is crucial. I want to highlight, brag on, Xavier University, a historically black college and university in my state of Louisiana. This week they announced an agreement with Ochsner Health to open a medical school in New Orleans at Xavier. And many of the doctors trained at Xavier, which has had a traditional mission to serve the underserved and to provide opportunity for minorities, they will stay in Louisiana and go elsewhere to serve those populations. So I'm proud of Xavier, and I look forward to continuing to support their effort. Now, as a doctor, I am so aware and desire to support those nurses who have climbed the career ladder by building credentials over time through upskilling. Despite from benefiting the individual, it benefits the capabilities of our workforce. It also benefits their family, as their child sees the impact of their mother or father seeking through education and delayed gratification greater opportunity that results in more prosperity. There's a woman I worked with named Olive who went from a nurse's assistant to a LPN to an RN to a nurse manager, and the clinic in which she formerly was the NA, she ultimately ended up being the manager of. Incredible story. We will have someone here today with a similar story. Dr. Jonas Andrades will tell us how she has done that in her career, and that is something that we need to think how to enable. We should also look at other challenges to ensure our healthcare system meets the need of all, especially the underserved. Making sure that patients from all walks of life can participate in clinical trials, which oftentimes gives the most advanced treatment to those who have the most advanced disease. And as I mentioned from my career, making sure that all have high-quality medical treatment is something I am passionate about. One of our witnesses today, Dr. Brian Stone, will tell us how he is trying to address these issues in his community. The committee will also discuss maternal mortality, a topic incredibly important that has been a priority of mine in Congress, and it's important to acknowledge that this issue disproportionately affects African Americans. As a doctor, again, who worked in Louisiana's charity hospital system, I know this community from my practice, and I know that this community is at high risk. That's why I'm pleased to have U.S. Representative and Dr. Michael Burgess testifying. He's an OBGYN who stayed up many nights delivering medical care to pregnant moms and their babies in an underserved population of Dallas. Now, as a legislator, Dr. Burgess is a leader in addressing racial disparities in healthcare, and it's been an honor to work with him on legislation specifically tackling maternal mortality. We were unaware that we were having a members of Congress panel until Sunday, so we greatly appreciate him joining us on short notice when actually they were adjourned last night. His participation helps make clear that Congress understands the severity of the issue and is working to address. I'm also proud to have led several bipartisan legislative efforts to improve maternal mortality and reduce healthcare disparities. In 2022, Congress passed the Maternal Health Quality Improvement Act, which helps address maternal mortality, particularly that disparity within African Americans. It also supports research examining the best practices to reduce and prevent racial discrimination in the American healthcare system. The same year, Congress passed my legislation, the John Lewis National Institute on Minority Health and Health Disparities Research Endowment Revitalization Act. It's a mouthful, but it's a good piece of legislation that provided funding to institutions, including Xavier, to conduct research and address minority health disparities. And last year, in this committee, we passed the Preventing Maternal Deaths Reauthorization Act, the legislation led in the House by Dr. Burgess, and the bill directs the CDC to provide hospitals and other providers information on best practices to prevent maternal mortality. This reauthorization has not yet become law, but we're pushing for passage as Congress. All this work shows a bipartisan commitment in Congress to addressing health disparities, but there is more to do. The Connected Maternal Online Monitoring Systems, or the Connected Mom Act, Senator Butler, I was about to demote you or promote you by calling you doctor, which I introduced with Senator Hassan of New Hampshire of this committee, promotes Medicaid coverage of remote monitoring technologies for those who are pregnant at higher risk of complications. The need for moms in underserved urban or rural areas to travel, sometimes hours, on public transportation to a doctor's office can be a major impediment to care. This legislation allows a physician to remotely monitor her health, watching for indicators of potential complications. It's bipartisan, it improves access to crucial health care for moms, and it prevents maternal deaths. While this bill is in finance jurisdiction, I look forward to the discussion today on how we can continue to make progress on maternal mortality in the HELP Committee. Thanks to our witnesses for being here and providing your expertise on how we better address these important issues. With that, I yield.
Thank you, Senator Cassidy. Our first witness will be Senator LaFonza Butler, Senator from California. Senator Butler is a longstanding advocate for healthcare workforce and increasing opportunities for students from underrepresented and disadvantaged backgrounds in the health professions. She is also a strong advocate for reducing maternal health disparities and combating the Black maternal health crisis. Senator Butler, thanks for being here.
Thank you, Chairman Sanders and Ranking Member Cassidy for the hearing today. Thank you to other members of the committee for joining. Your leadership on this issue is demonstrable. Thanks for having me. It's an honor, truly, to sit before today's committee to bring added amplification to the lack of diversity within our nation's healthcare system, as you both have outlined so clearly, and in addition, the worsening maternal health crisis. Before I begin my testimony, I would like to acknowledge those leaders who have been championing this issue prior to my arrival in the United States Senate. It is leaders like Representative Lauren Underwood, our colleague Senator Booker, who introduced the Black Maternal Health Momnibus in the Senate, and Representative Alma Adams for their leadership in developing the Black Maternal Health Caucus and the leadership. I also could not sit here without recognizing Vice President Kamala Harris, who introduced the first version of the Momnibus while serving in the Senate. She continues to lead the Biden-Harris administration's efforts to improve maternal health outcomes. These are champions that I am proud to stand alongside. I want to also take a brief moment to highlight Dr. Michael Galvez, who's a witness in today's hearing and is also a resident of California and one of my constituents. Dr. Galvez is a board-certified plastic and reconstructive surgeon specializing in pediatric hand surgery in Valley Children's Hospital in Madera, California. He co-created National Latino Physician Day to bring attention to the fact that while Latinos make up 19% of the population, they account for only 6 to 7% of the physician workforce. Thank you for being here today, Dr. Galvez. Our healthcare system and the state of maternal health in this country is at an inflection point that requires the urgent attention of this committee. The numbers should alarm all of us. The United States has the highest rate of maternal mortality among high-income nations. Within recent years, thousands of women have lost their lives due to pregnancy-related causes. And over the past decade, while the birth rate in this country has declined by roughly 20%, maternal mortality rates have steadily risen. The crisis is exacerbated in communities grappling with the lack of access to essential maternal health care. According to a report produced by the March of Dimes, 1/3 of counties in the United States are considered maternity care deserts, meaning there are no hospitals providing obstetric care, no birth centers, and no obstetric providers. Think about that. Imagine your loved one preparing to give birth and bring new life into your family and having no choice but to drive hours away from home to seek the care they need. We know from the research and the numbers that this crisis has not been felt equally. Among Black and Native Indigenous communities, maternal mortality rates are 2 to 4 times higher compared to those of white communities. 2 to 4 times higher are Black and Native American women more likely to die in a pregnancy-related death. While Black and brown communities experience the highest rates of maternal mortality and morbidity, these populations also remain starkly underrepresented within the healthcare field. While an estimated 13% of our country's population identifies as Black, only about 5% of physicians in the United States are Black. Research suggests that under the care of Black physicians, the mortality rate for newborns decreases by over 50%, which is why I applaud and urge this committee's continued efforts to not only bolster the healthcare workforce, but to use every tool to ensure that that workforce is diverse and equipped to provide unbiased, culturally competent care. Only then can we begin to change the course of our nation's current healthcare system. And we know that this must not mean focusing exclusively on physicians. For families, mothers, and babies, this means doulas and nurse midwives, nutritionists, and the full spectrum of reproductive healthcare professionals that contribute to their health, well-being, and birthing experience. Having access to a comprehensive care team can make the world of difference for families. For example, in my home state of California, the Martin Luther King Community Hospital in Los Angeles has reimagined the birth experience for women serving within its service community. When I visited the hospital, I saw firsthand how doulas and nurse midwives were integrated into their overall maternal health care model to ensure that birthing mothers receive the highest quality, most comprehensive care. The leadership of Dr. Elaine Batchelor has made an indispensable difference. And even as we have existing models and we consider other proposed solutions to this crisis, I implore this committee to advance the Black Maternal Health Momnibus Act led by Senator Booker. The Momnibus is comprised of 13 individual bills that would combat the Black maternal health crisis and make historic investments to address comprehensively every driver of maternal mortality, morbidity, and disparities in the United States. This legislation is not just about the life and death of Black women. Its enactment will improve birthing outcomes for all women. The Momnibus includes bills such as the Kira Johnson Act, which would make necessary investments in community-based organizations that are leading the charge to protect mothers and support culturally competent training within maternity care settings. This bill is named after Kira Johnson, a Black mother who in 2016 checked into a hospital with her husband Charles to give birth to their second child, Langston. Despite being in excellent health, Kira died from a hemorrhage in the hours after delivering young Langston. Kira should be here today. The lives of her husband and her sons have forever been changed. The Johnson family's tragic experience and that of so many other families should be a wake-up call for us to act with urgency to address the need of unbiased, patient-centered care. Today's hearing is an important step in the right direction. I urge this committee to hold additional sessions focused on the Black maternal health crisis and important legislation that my colleagues and other advocates have introduced and researched. This committee, which holds the primary jurisdiction for the Black maternal health momnibus and so many other maternal health policy solutions, has had a recent hearing on the topic. Last month, during Black Maternal Health Week, I convened a roundtable of prominent maternal health leaders and experts for a discussion on how we can work together to combat the maternal health crisis. We discussed the hurdles that lie ahead in advancing the momnibus and similar legislation. Those advocates shared with me that they believed that they would have to remove the word Black from the title of the momnibus. They believed that only then would the legislation be likely to gain the necessary support for passage. After spending some time with my colleagues in the Senate, spending time with many of you, I don't believe that to be true. I know this committee is filled with senators, public servants, who represent Black women living in each of their states. I'm here to stand with you and to show every American watching that I stand with leaders on this committee who together demonstrate our commitment to the Black and brown women and their families who suffer the most in our healthcare system. We have solutions at the ready, and I know that anti-Black sentiment will not serve as a barrier towards progress. While I serve in this chamber, I'll continue to stand with all of you loudly and proudly, ensuring that we deliver the investments required to meet this moment for caregivers, healthcare personnel, the mothers and families in California and throughout the nation. I look forward to working with this committee and my colleagues in both chambers as we advance comprehensive solutions and utilize every level to prevent maternal deaths in this country. Thank you.
Well, thank you very much, Senator Butler. Our next witness will be Congressman Michael Burgess, representative from Texas. I think, Senator Cassidy, you wanted to introduce the congressman.
Yeah, it's a pleasure to introduce a witness and a friend, the Honorable Michael Burgess, an OBGYN. I represented for 20 years the 26th District of Texas in the House of Representatives. He's the chair of the Budget Committee of the Health Care Task Force, chair of the Rules Committee. He serves on Energy and Commerce. He has used his wealth of knowledge in maternal health and in building the healthcare workforce to advance key pieces of legislation addressing these issues. And he has, as you might guess, a unique perspective as both a policymaker and as a practitioner. So, Dr. Burgess, thanks for being here.
Thank you, Dr. Cassidy. Chairman Sanders, members of the committee, thank you for allowing me the opportunity of testifying here this morning. I do represent the 26th district in the state of Texas. You know, in the House, we have congressional districts. So that's the area near the Dallas-Fort Worth Airport to locate it for you. Before coming to Congress, I spent nearly 3 decades practicing medicine in that area. Look, I know practicing medicine can be very complex. I chose obstetrics because if there is attention to detail, the results can almost always be satisfactory. I spent time in residency as an OB-GYN at Parkland Hospital. Statistically, Parkland has some of the best outcomes in the country due to its emphasis on proper care and attention to detail. When I started my residency, I remember Dr. Jack Pritchard, who was the leader of the Department of Obstetrics and Gynecology at the time, pointing out that in practicing OB, you're unique in medicine. Those privileged enough to continue were going to be charged with taking care of the simultaneous care of 2 patients with a combined life expectancy of 100 years. Nowhere else in medicine does that occur. The patient population for Parkland, the Dallas County Hospital District, serves both rural and urban communities in and around Dallas. In my time, the clientele was multi-ethnic, almost completely uninsured or underinsured. But again, they have some of the best statistics in the country. And the lesson for me there always was, it doesn't have to be this way. You can do better. And I would like for us to focus on that with whatever our public policies are going forward. For myself, I've delivered in private practice over 3,000 babies, treated patients who've suffered from miscarriages, ectopic pregnancy, stillbirth, sickle cell, and other life-threatening conditions. Whether my responsibility was to step in and deliver a baby or save a life, I did it without hesitation. For this reason, I've spent my career trying to increase access to quality health care for patients through both my experience as a physician and a legislator. In 2005, through what I describe as the miracle of redistricting, I picked up an area on the east side of the city of Fort Worth. It had one of the highest infant mortality rates in the country. And despite the challenges, it took years of concerted effort, but eventually I was successful in getting a federally qualified health center with a pediatric unit in that part of Fort Worth. Collaboration with a Democratic County Commissioner, Roy Brooks, the Mayor of Fort Worth, Mike Moncrief, who was a prior Democratic state senator. It was through that joint effort and the experience and the expertise and the passion that led us to championing those issues. Now in Congress, I've continued that as well as other health care issues that improving the health of the nation. The alarming trend of our country's rate of maternal mortality first came to my attention in September of 2018 in my copy of the Green Journal, the Journal of Obstetrics and Gynecology. The original research cited in the journal stated that the maternal mortality rates increased in Texas between 2011 and 2012. But then a new study found that the number of maternal deaths in Texas in 2012 was actually half than the number previously reported. In other words, there was a mistake in the arithmetic. Because of that, the focus became on how things were counted rather than how do we prevent these bad things from happening. The study was retracted, but again, the discussion became about the numbers, not about the patients, and that was unfortunate. I personally believe one maternal death is too many. And it's important that we capture these deaths accurately to understand the scope of maternal mortality in the United States and my state of Texas, and that we have a better understanding of how to address them. In combination, we cannot legislate good practice, but we can provide the tools to be able to come up with the best practices and increase access to maternity care. These critical points have influenced my policy work. And there's some actual tangible results from that. Because of the Preventing Maternal Deaths Act, which was signed into law in 2018, and increasing the dollars spent on maternal mortality review committees, it actually came to my attention that 53% of maternal deaths were occurring 1 week to 1 year after delivery. I had been focusing on that time actually in hospital, but by broadening the lens out a little bit, more lives can be saved. And as a consequence, now there was an amendment, a state plan amendment available to Medicare, to Medicaid and CHIP programs that has allowed inclusion of postpartum care up to a full year after delivery. Texas, I am happy to say, enacted that March 1st of this year, and now new moms in Texas are going to have the benefit of an additional year of postpartum coverage. 3338, which was referenced in Senator Cassidy's opening remarks, has passed the House, and I encourage you to look at that in the Senate. I think we can do more with our approach that the multidisciplinary maternal mortality review committees and the causes of maternal deaths. I cannot stress enough the importance of continuing bipartisan work to reduce disparities and improve outcomes. We can bolster our public health workforce. We can actually start by paying our doctors so they don't retire early or never enter the practice of medicine in the first place. That has been a particular concern of mine since coming to Congress. Repeal of the sustainable growth rate formula and the approach to value-based care that followed in its place, although it's imperfect and we've still got a ways to go. These are important parameters that will benefit all Americans. I've had the good fortune of working with your future colleague, Lisa Blunt Rochester, soon to be a senator from Delaware, my understanding. I also work with Robin Kelly and Danny Davis, working with Danny Davis to improve the care of the sickle cell patient, which importantly really had not received any new FDA-approved therapies in over 40 years until we began to work on that right after the Cures Act passed. I know my time is done, but I just want to stress that there are important things we can work on together, House and Senate, Republican and Democrat, and it's our obligation to those future Americans that we do so. This generation of doctors that's coming up is going to have tools to alleviate human suffering that no generation of doctors has ever known. It's our job to deliver that to them in a timely fashion. Thank you for your attention this morning. I yield back.
Well, thank you very much, Congressman Burgess. Thank you very much, Senator Butler. We appreciate your testimony and your excellent work. We will now hear from our second panel. Thank you. Let me thank all of our knowledgeable panelists for being with us this morning. And we have 5 panelists, Dr. Yolanda Lawson, Dr. Samuel Cook, Dr. Michael Galvez, Dr. James Andreades, and Dr. Brian Stone, and we thank all of them for being here. Our first witness will be Dr. Yolanda Lawson. She is president of the National Medical Association, the largest organization representing Black physicians. Dr. Lawson is an OB/GYN who is committed to addressing health inequities and improving diversity among physicians. She is also committed to eliminating maternal health disparities. Dr. Lawson, thanks so much for being with us.
Thank you. Good morning.
Is your mic on? Press the button there.
Okay. Good morning, Chairman Sanders and Ranking Member Dr. Cassidy and members of the committee. Thank you for the opportunity to appear before the committee to discuss this critical issue, addressing the shortage of racially minoritized healthcare professionals and maternal health disparities. I am Dr. Yolanda Lawson. I'm testifying today as an OB/GYN practicing in Dallas, Texas. I'm founder of Madewell OB/GYN and Madewell Woman, which is a birthing center. I'm currently the executive medical director for Maternal Infant Health at Healthcare Services Corporation. Today, I speak to you primarily in my capacity as the president of the National Medical Association. We are the largest and oldest national organization representing more than 50,000 African American physicians and the patients they serve of all racial and ethnic backgrounds. As a physician, my first duty is to the health of my patients. As NMA president, my first duty is to fulfill our mission to eliminate health disparities in this country. The sad fact is, African Americans, as well as other people of color, are not as healthy as their white counterparts. African Americans experience the lowest life expectancies across a myriad of health outcomes compared to white Americans, irrespective of their socioeconomic status. Research demonstrates that such inequities in health outcomes have existed since federal record-keeping began, and they cannot be explained solely by socioeconomic differences, and they are largely preventable through structural interventions and through the implementation of equitable health policy and measures before a prospective patient even enters a traditional medical setting. In 2020, our nation watched in horror as Black people died disproportionately in high numbers from COVID-19. That extraordinary moment spotlighted a chronic problem of the ongoing health disparities that exist for Blacks in this country. Black people are disproportionately affected by virtually every major chronic disease, including diabetes, high blood pressure, and obesity. Even more disturbing are disparities in maternal health. You all know the numbers. Black women are 3 to 4 times more likely to die from pregnancy-related complications than white women, and maternal health disparities persist as a pressing public health challenge in the United States, despite advances in medical technology and healthcare delivery. These disparities are not solely attributable to socioeconomic factors, but are deeply rooted in systemic racism and unequal treatment, bias, and inadequate access to quality health care. This is not just a matter of equity or fairness. When there are more sick people in our nation, such an imbalanced dynamic creates a bigger burden on our healthcare system, reduces workforce productivity, increases disability, and raises medical costs that ultimately we all pay for, whether through Medicare, Medicaid, or other high health insurance premiums. Avoidable health disparities are deeply rooted in the operationalization of structural and systemic racism and discrimination, and in the persistence of unequal access to quality health care. Each of these elements erodes a patient's healthcare experience and diminishes their ability to make the best choices in support of their health today and across their lifetime. So today, I'd like to emphasize a critical piece of the American healthcare puzzle: the shortage of Black physicians. Research consistently demonstrates that patients from racial and ethnic minority backgrounds experience better outcomes when treated by healthcare providers who share their racial and ethnic backgrounds. In short, patients can have better health outcomes when their doctors look like them. Yet, Black doctors remain vastly underrepresented. Representation is critical, and Black physicians and healthcare providers are more likely to understand the unique challenges that Black patients that affect Black patients' health. Black patients are more likely to trust and comply with the recommendations of a Black physician. This country has a legacy of distrust among American healthcare institutions, rather real or perceived, and this is rooted in historical abuses of power. 70% of all Black physicians in the U.S. today attended HBCUs. In the early 20th century, we know that number was reduced after the Flexner Report was released. Instead of addressing those concerns about the quality of education at HBCU medical schools, the AMA allowed them to close. We know that likely the number of Black physicians in this country today would be more proportionate to the Black population if those institutions had remained open. The NMA believes we must create pathway programs to address inequities in the education system. We must address financial constraints. For many Black students, medical school is a financial impossibility. We support programs such as the National Health Service Corps and ask for resources for the HBCU medical schools to address education and infrastructure. Medical schools must adopt more holistic admission processes. We must address the higher attrition rates among Black medical students and residents. We advocate, in regards to maternal health, a companion bill from the Senate to the Black Maternal Omnibus Act to focus on preventable maternal mortality. And finally, we must take steps to reduce the bias in our healthcare system by establishing regional centers of excellence to address implicit bias and cultural competency in health profession settings, like Senator Durbin and Representative Robin Kelly's Care for Moms Act. So I believe we're at a turning point in my lifetime. 2 major events have significantly exposed the disparities between the health of Black people compared to those of our white counterparts: the COVID-19 pandemic and Hurricane Katrina. Both catastrophic events revealed the glaring health inequities that are present in our country. There is much work to do, but we also have a historic opportunity to change the story. Thank you, Senator.
Dr. Lawson, thank you very much. Our next witness will be Dr. Samuel Cook, a resident physician at Morehouse School of Medicine. Dr. Cook received his medical degree from Drexel University and is an advocate for improving diversity of the physician workforce. Dr. Cook, thanks very much for being here.
Thank you, sir. Senator and Chairman Sanders, senators of the HELP Committee, my fellow esteemed panelists and guests, thank you so much for having me here today. I'm Dr. Samuel David Cook, a PGY3 internal medicine resident at Morehouse School of Medicine. I was born and raised in the Bronx, New York by my two loving parents, Ronald Cook and Ambassador Susan Johnson Cook, who instilled in me a deep love of God and the impetus to serve those among us who are most in need. Though all of us in this room today are red-blooded Americans, my journey to this platform has been anything but traditional. The doctors I saw as a child never looked like me, so I made it my life's mission to be the change I sought in medicine. During my undergraduate studies at Johns Hopkins University, I was told by my medical school admissions counselor that my above-average GPA at one of our nation's top 10 universities was not strong enough to make medicine a reality. Nevertheless, I persisted and entered a post-baccalaureate pipeline program for underrepresented minorities at Drexel University's College of Medicine. In this Drexel Pathway to Medical School program, I thrived in the specialized and supportive environment and quickly excelled. I then graduated to become a medical student at Drexel, where I earned top academic awards above my peers of all races and published my medical research, even authoring a paper with decorated physicians at Harvard's medical school. As the sayings go, you can't judge a book by its cover, and it takes a village to raise a child. It is a fact, not an opinion, that historically black colleges and universities have been instrumental in creating their own pipelines to medical schools. Between 2009 and 2019, HBCUs sent the most black graduates to them. Last year, HBCU medical schools produced 10% of our nation's black doctors, while only accounting for 2% of all medical colleges. Assuming we beat an educational system that is stacked against us, many black students are then faced with hundreds of thousands of dollars in student loan debt. For me, the current sum of medical student loan debt plus accrued interest stands just shy of $400,000. Though the costs are the same no matter the student's race, the financial impact it will have on their families is not. Racially based and systemic wealth inequity is an undeniable truth in our nation, and one that has barred far too many students of color from becoming the doctors they were qualified to be. Thus, we call on you to increase funding for HBCUs to reduce the cost of producing high-quality physicians of color. This is with the understanding that these institutions have a proven track record of incubating some of our nation's brightest minds, those nearly snuffed out by the waves of racial bias and injustice. So how does having a black doctor better serve black patients or save them from undue harm? I wrote in my testimony about a black woman who was nearly committed and chemically and physically restrained, all because her medical team didn't know that hitting your head to scratch an itchy scalp doesn't make you crazy. It simply means you don't want to mess up your hair. And how it was the presence of a black psychiatrist that saved them and that hospital from what would have been justifiable malpractice lawsuits. So this is not just an issue for black American senators. This is an issue for all Americans. What's more, a 2016 study found that half of white medical trainees surveyed, 50%, believe such myths as black people have thicker skin or less sensitive nerve endings than white people. They continued, participants who endorsed these beliefs rated the black patient's pain as lower and made less accurate treatment recommendations. In this population of white medical students, we see evidence that negative racial biases are currently and have long been harming America's black patients. Senators, I humbly come before you today as nothing more than a mouthpiece for our collective struggles. We serve tirelessly, senators. We, resident physicians and medical students of color, sacrifice our physical, mental, spiritual, and financial well-beings to be the change in the medical field we so desperately seek. So now we ardently advocate for the reintroduction of legislation which would specifically fund and protect the growth of HBCU medical schools, like that proposed by Chairman Sanders in 2023. This is with the sentiment that we make these vital pipelines more affordable because the financial manacles of medical schooling are the greatest impediments in recruiting Black and brown doctors to our workforce. It frightens me to think that after today, nothing will change to render our physician workforce more representative of the racial and ethnic makeup of our great nation. Therefore, I am challenging you, senators, calling upon you to each assure the American public and your constituents that you will vote to support our HBCUs and empower future generations of Black and brown physicians. The time to act is never tomorrow, senators. It has been and it always will be today. Thank you.
Thank you very much, Dr. Cook. Our next witness will be Dr. Michael Galvez, who specializes in pediatric reconstructive hand surgery in Madera, California. Dr. Galvez co-created the National Latino Physician Day and the phrase, 6% is not enough, to bring attention to the need to diversify the physician workforce. Dr. Galvez, thanks so much for being with us.
Buenos dias, Chairman Sanders and Ranking Member Cassidy. Thank you for having me here today. My name is Dr. Michael Galvez, and I stand before you as a husband, father, son of Peruvian immigrants, surgeon, and an advocate for mi comunidad, my Latino community. I am honored to serve as a pediatric hand surgeon to help children with complex hand conditions at Valley Children's Hospital in the Central Valley of California, a region with significant disparity and need for high-quality care. Hablo español todos los días. I speak Spanish every day with my patients. In my practice of medicine, I've come to recognize that my language and culture are as valuable as my training at prestigious universities. There is nothing like seeing a face of a Latino child's mother when I come through a clinic door and begin speaking Spanish, alleviating fear as their first encounter with a physician that speaks el idioma, the language. I see complex problems, and having the superpower of language proficiency and understanding the culture adds clarity and connection. After working at medical institutions across the United States, I've asked myself constantly, why don't I see more students and faculty like myself? For that reason, I helped co-found National Latino Physician Day, celebrated on October 1st, along with Stanford obstetric anesthesiologist Dr. Cesar Padilla, to spotlight the underrepresentation of Latinos and Latinas in medicine. This effort has rapidly evolved into a movement supported by the National Hispanic Medical Association, the Latino Medical Student Association, and nearly every medical organization in this country and multiple hospital systems across the country. We rally behind the motto, 6% is not enough, in recognition of the public health crisis affecting our community. Despite being the largest minority group in the United States, Latinos represent only 6.9% of the physician workforce, which is a big contrast to almost 20% representation in the nation's population and nearly 40% in the states of California and Texas. There are not enough physicians to provide high-quality care to communities that are the backbone to our economy and overrepresented in difficult professions such as agriculture and construction. Latinos in the U.S. have the 5th largest gross domestic product in the world, GDP. However, limited access to healthcare, face language and cultural barriers, experience poor cancer and maternal health outcomes, and had increased COVID-19 mortality during the pandemic. This deeply burdens the nation's social safety nets, more missed school days for children, and lower productivity, which really stunts the potential of our country. Our hospitals, our institutions, medical schools, and indeed Congress have the ethical responsibility to address the underrepresentation of Latino physicians to meet the needs of a growing Latino population, which is estimated to comprise 1/3 of the population by 2050. But the journey to medicine is full of socioeconomic barriers, especially for Latino and minority students. In my journey, community college education was key to my success. But it can really just be the only educational option for some students. To expand the percentage of Latino physicians and minority physicians in general, it is critical to meet them where they are, and that is in our nation's community colleges. The commercialization of medical school admissions and the reliance on standardized tests, such as the MCAT, overlooks the potential of a compassionate and capable physician candidate. Having helped excellent students navigate these waters, I'm in disbelief when they're not recruited despite our physician shortage. The National Latino Physician Day highlights the persistent shortage of Latino physicians, which underscores the need for change and opportunities for action that Congress can take. First, expand funding for pathway programs and new medical school programs. We can increase the minority physician workforce by recognizing the value of lived experience of Latino-identified individuals through pathway programs that begin at community colleges, earlier exposures to medicine, and advocate for holistic medical school admissions. We need a bilingual and bicultural medical school anchored in a Hispanic-serving institution, partnered with local hospitals. We can start with regional satellites of medical schools in predominantly Latino areas of California. We also should not be ignoring language. Language proficiency by physicians is a proven strategy for improving patient outcomes demonstrated by the UCLA Latino Policy and Politics Institute, which has shown that concordant language enhances compliance with treatment plans and medication adherence. Mandating medical schools to value bilingual skills and community college background. By tying medical school funding and NIH grants to admission practices that prioritize these elements, this will drive medical schools to align more closely to their local underserved areas. For example, the University of California could be mandated to recruit, accept, and retain these qualified students to take care of those underserved populations. Finally, funding loan repayment programs. In California, I am grateful to be the recipient of a Cal Healthcare's loan repayment to serve patients on Medi-Cal. But federally, the National Health Service Corps is essential to attract and retain physicians in underserved areas, ensuring equitable healthcare access. We can no longer allow the status quo from our medical schools. As the Latino population increases, we must confront this public health crisis head-on. Necesitamos más, we need more. Thank you so much.
Thank you very much, Dr. Galvez. Senator Cassidy, do you want to introduce your panelists?
Yes, my pleasure to introduce Dr. I'm sorry. Dr. Janice Andrades, who is a certified nurse practitioner who completed her Doctor of Nurse Practitioner at Elms College 2020 and her Bachelor of Science in Nursing from Elms College in 2014. She's a native of Springfield, Massachusetts, dedicated her professional career to caring for vulnerable populations with addiction, mental illness, and chronic disease. She credits her pre-nursing experiences in the hospital setting as a catalyst to pursuing a career in healthcare. Her clinical experience as a registered nurse began as a correctional nurse for the Hampton County Sheriff's Department, where she conducted mental health evaluations and incorporated a multidisciplinary approach to care. Later joined the Bay State Mason Square Neighborhood Clinic, providing drug and alcohol abuse nursing care. She enhanced her clinical skills as an inpatient staff nurse and joined Bay State Medical Center team as a trauma surgery nurse practitioner in September 2020. Her commitment to be a voice for the disenfranchised has allowed her to be a change agent and a role model for others. Dr. Andrades, thank you for being here.
Chairman Sanders and Ranking Member Dr. Cassidy, I am Janice Andrades, a nurse practitioner in trauma surgery at Bay State Medical Center in Springfield, Massachusetts. It is an honor to present my testimony before you today, and I thank you for the opportunity and your attention to addressing the shortage of minority healthcare professionals. I want to tell you a bit of my experience and offer you some insight into ways I believe Congress can help increase the number of minority healthcare workers in the future. I went to high school in Springfield, Massachusetts at Putnam High School, an urban vocational school. I was enrolled in the cosmetology program, but had dreams of becoming a lawyer. At that time, I struggled to figure out how to make this dream come true. Coming from a single-parent home where my mother didn't have the means to save for college or law school, I was fortunate, though, she did have the drive to instill a strong work ethic and the foresight to encourage me to contemplate my talents and choose a career which would offer economic stability. One day, at a medical appointment with my mom, a nurse started talking to me about the opportunities nursing could offer. I was intrigued. To get a better sense of how I would fare on the path to becoming a nurse, I started taking courses at Holyoke Community College. I took prerequisites for the nursing program and eventually enrolled to Elms College to earn my bachelor's of nursing. While I was going to school, I wanted to support myself and thought taking a job at a hospital to get my foot in the door and learn more about healthcare would benefit me in the long run. So I began working in environmental services as a custodian at Bay State Medical Center. I worked to keep surgery and procedure rooms clean. This allowed me to see firsthand what nurses did, what I would need to know moving ahead in the healthcare environment, and to get advice on how to proceed in my career. My colleagues offered incredible insight into ways I could fund my education. They pointed me towards resources like the Western Mass Community Foundation, where I had access to scholarships and interest-free loans. Without my colleagues, I would not have been able to find these resources, which I believe were instrumental to my education. These resources need to be made more visible and accessible to students. I proceeded through my nursing school and stayed at Bay State Medical Center in environmental services. Eventually, I was hired as a nurse once I graduated in a community health center, Mason Square. There again, with the support of my colleagues, I was encouraged to earn my doctorate of nursing practice. I did this at the height of the COVID-19 pandemic, which was not easy, and eventually I was able to come full circle and take a job as a nurse practitioner in trauma surgery, again at Bay State Medical Center. Looking back on my experience, if I could make suggestions to lawmakers on how to improve the shortage of minority health care providers, I would offer a few thoughts. First, I would say robust college and career planning is very critical. Many students at all schools, most especially those in lower income areas, aware of health care as an attainable career opportunity would go so far. Letting these students know it is within their reach and that there are resources available to them to embark on their journey to higher education is key. At Bay State Medical Center, we have a program called the Bay State Springfield Educational Partnership, or BSEP. This is a program for the youth in Springfield, which helps connect them with hospital-based learning and opportunities to learn about different professions within the healthcare system. It allows students to engage with professionals and learn from them, like I did while being a custodian. But in this program, they're still in high school, and this option helps them evaluate what healthcare career they could select. I did not go through this program myself, but I would recommend supporting similar opportunities for minority youth for early professional mentorship. There are a number of physicians, physician assistants, and nurse practitioners like myself who entered BSEP as high school students and now work for Bay State. Many of the BSEP students also fill other roles in Bay State while advancing their education. I believe federal support for programs like this could lead to many more minority students embarking on prosperous careers in healthcare. Another way to make this journey more accessible is tuition-free community college. This would allow students to begin their education without taking on a financial burden. This opportunity to begin to pursue the education needed to become a professional healthcare provider at a community college should not be underestimated. Additionally, state and federal grants to reduce loan costs would make their career paths a more appealing option. Helping fund the education of minority students interested in becoming professional healthcare providers is a wise investment. It fills in demand jobs in the healthcare field and connects people with practical careers, which will allow them economic stability to support themselves and their families. Thank you again for the opportunity to testify and share my experience with you. I appreciate your consideration of my recommendations.
Senator Cassidy, you want to introduce your last witness?
And I'll let my senator from Alabama introduce the doctor from Alabama.
Thank you, Senator Cassidy. Welcome to all of you. It's my honor to introduce today Dr. Brian Stone of Jasper, Alabama. Dr. Stone grew up in Birmingham and received his undergrad degree from Rutgers. He went on to earn his medical degree from University of Alabama, Birmingham. He was identified as a top urologist in New York and New Jersey in his years of tenure at Columbia University's College of Physicians and Surgeons. He has received so many awards for his success, it's hard to count them all, but he's been honored by the NAACP, the Morehouse School of Medicine, the American Cancer Society, and the American Urological Association. Because of his leadership on issues like health disparities and prostate cancer, he has served in many capacities as a consultant and scientific advisor. He has served in advisory positions on the local, national, and international level over the years. He also worked in partnership with pastors in different denominations in Jefferson County and the Jefferson County Department of Health to educate and recruit black patients to participate in clinical trials process. And he serves on the Committee for Underrepresented Minorities at the University of Alabama Birmingham School of Medicine in conjunction with School of Medicine's National Alumni Association. He created a medical scholarship program for deserving male students of color from Alabama who have been accepted into the UAB School of Medicine. The goal is to increase the number of minority physicians who are from Alabama and are willing to practice medicine in the state. He has also worked to increase STEM exposure to K through 12 students in the city of Birmingham in partnership with the Boys and Girls Club. Dr. Stone is currently the president and chief medical staff of Walker Baptist Regional Medical Center and the president of Jasper Urology Associates. I couldn't be more proud to have him here today, and we all look forward to his testimony. Thank you, Dr. Stone.
There we go. Good morning. I'd like to thank Chairman Sanders, Ranking Member Cassidy, Senator Tupperville, and members of the Health Committee for having me present to speak today. My background is a urologist. I think I'm the old guy on this committee. I graduated in 1985. I've had a breadth of experience working in the inner city, having trained in the Bronx, having worked at Harlem Hospital, which was connected to Columbia University, and I'm now in a rural setting, and I see the similarities between the health problems that we see in the inner city as well as in rural America. When I think of America, I think of the saying that you can't choose your family, but you gotta love them anyway. Our diverse people make our country the greatest country in the world. But our greatness cannot be maintained if we can't keep our people healthy. Currently, we have about 71,000 physicians retiring per year over the past few years, and we're only graduating 21,000 medical students per year. And if you follow the mathematics, you see where we're going to end up. We're going to need some very creative ideas to get us out of this situation. The impact of the low numbers of physicians has downstream impact on the number of specialists. And we feel that at our hospital now with our inability to recruit physicians in various specialties. An unhealthy nation is a less productive nation. Certain segments of American population are less healthy than others, as other speakers have spoken about. Black Americans have the highest death rate from all causes in our country. These high rates of disease and death have economic consequences, and that is why this is important for us to address. I grew up in a segregated Birmingham where every black, regardless of his socioeconomic status, lived in the same neighborhood. This had benefits because I had the opportunity to grow up with role models like Dr. James Montgomery, Dr. Clarence Hickson, Dr. Herschel Hamilton. My uncle, Dr. Warner Meadows, was one of the first black surgeons in Atlanta. These role models made me know that I could be whatever I wanted to be. But that's not the case for a lot of kids in America today. Unfortunately, technology has almost become an impediment to educating our children. And America appears to be at a major inflection point in how we educate our children, because this is the pool from which physicians are recruited. America and the black community have a serious challenge in addressing the STEM gap that exists between white and black students. Richard Coley and Barton noted that progress was being made in recruitment of African Americans to medical school, but this peaked in 1994. A 2018 Pew Research study showed that the poor foundation of STEM education in K through 12 was the root cause of the recruitment problem for medical schools of medical students. There's a wealth of data showing better health outcomes when black patients have black physicians. and this applies across different cultures. And this is because when you have cultural connectivity, you have better communication, you have shared experiences, and you can overcome the mistrust that has developed over the decades. Alabama has a population of 4.8 million people, 25.8% of whom are black, and yet we only have 7% of the physician workforce that's black. We're dealing with some serious healthcare issues in our state, particularly with limited access to healthcare in many of our rural areas. We've had closure of many of our rural hospitals and clinics, particularly in the black belt of the state, and we got to come up with some real solutions. Most of our physicians tend to be concentrated in the major metropolitan areas of the state, leaving our rural areas at risk. It's no wonder that Alabama always ranks at the lowest as far as health amongst states in the area, and it's not only is the overall health of Alabamians poor compared to residents of other states, but the health disparities between African Americans and whites are very considerable. What are some of the potential solutions? Enhancing K through 12 STEM education, incorporating mentors early, creating a health-focused fast track to fast-track students into medicine, reducing the financial burden of medical education, increasing the size of medical school classes, increasing the size of residency training programs. The problem cannot be corrected overnight, but the crisis is real, and I think we need to start thinking out of the box. Thank you very much.
Well, let me thank all of the panelists. Every one of you made extremely important issues, and I hope very much that this committee will act on some of your thoughts. Let me start off, and I must confess that until fairly recently, I did not appreciate this issue. Until a couple of years ago, we had some young people from Howard University coming into the office, and they were chatting, and one young woman was talking about the experience her mom had going to a physician's office and not being taken seriously and so forth. And I know all of you in various ways have raised the issue. So let me ask, I think many Americans would say, hey, there's a physician. What difference does it make, white, black, Latino, who cares, as long as a good doctor? What difference does it make for going to a physician who kind of understands your life, maybe comes from your community? What difference does it make? Dr. Lawson, you want to start? We'll go right down the line.
Absolutely. It makes a huge difference. Me, myself, in practice, many times the trust, when I build trust, my patients really do respect and comply with therapy. It is not uncommon for me to experience many of my patients may go to, a physician of a different race or ethnicity and question, right, the treatments that they're prescribed, or have given me or provided personal experiences where they weren't respected within the system, or they were provided treatments that were inadequate or substandard, or not even given options, especially being an OBGYN. I don't have to tell you that historically so many women, black women, Latino women, underwent hysterectomies unnecessarily. The options of childbirth were taken away from them. And so these are everyday experiences.
Good, thank you very much. Please be brief. I want to hear from everybody. Dr. Cook?
Yes, sir. Thank you so much, Chairman Sanders. It is really an issue of cultural competence. You don't understand the perspectives and the concerns of people from other races as well as they do for themselves. We grow up in similar situations. We know very similar circumstances that happen to all of our families. And as Dr. Lawson alluded to, there's an inherent mistrust. We saw that even with COVID vaccinations and the inability to get Black Americans to even take those vaccinations. So it's a widespread problem, and it will only improve with more representation.
Thank you very much. Dr. Galvez?
Yeah, for the
microphone, yeah.
Thank you. For the Latino population, the patient-physician concordance is so important to have that cultural competency, to decrease miscommunication. And the language component for Latinos in particular is very important because things can get lost in translation. A story I can think of is a patient comes in, their child needs a surgery, has a congenital hand difference, and everything gets discussed in the visit, but the family is more worried about general anesthesia, and that question doesn't get asked or doesn't get fully addressed. And so they leave the visit. They maybe book the surgery because someone said, just, we're ready to do the surgery, you got to fix this problem. They book the surgery, but then the patient just cancels because they're so concerned and they didn't get their questions answered. And so that miscommunication results in delays in care.
Dr. Andreades.
I think, for patients, especially in my field of trauma surgery, I meet patients on their worst day. I am of Puerto Rican descent, so in being able to speak to someone who just went through a terrible car accident or some trauma, I think gives them a breath of fresh air. And again, as the other panelists have alluded to, it's the trust that you have someone that speaks your language and looks like you at the forefront of your medical care. And I think that really makes a difference in patient satisfaction and patients trusting the healthcare system.
Thank you. Dr. Stone.
I deal with it daily when it comes to, say, prostate cancer, the difference between a black male and how he communicates and a white male, the concerns they may have, the trust factor, all of that plays into the relationship and patient compliance.
My last question, briefly, I'm running out of time here. Dr. Cook mentioned that he graduated medical school $400,000 in debt. I've talked to doctors graduating with more debt, nurses graduating with a whole lot of debt. Generally speaking, Black, Latino, Native American communities are poorer than white communities. What does the financial constrictions mean to young people in minority communities who want to pursue a career in medicine? Dr. Lawson, briefly.
Absolutely. The financial implications can almost make it impossible to pursue the degree or be very discouraging to individuals. I myself am working on scholarships for students, but I encourage anything that we can do. I myself participated in many disadvantaged programs to fund my medical education, but I was told that I couldn't do it literally because my family did not have the resources.
If people could go to medical school without having to worry about tuition or student debt, would that make a difference in your communities, Dr. Cook?
Of course, the price tag in itself is a barrier. Think for 1 second, if you took out $400,000 of debt and you got sick in your first year of residency, you will have no way to repay that. You will be forever in debt.
Dr. Galvez?
Those socioeconomic differences make a big difference, and the difference for Latinos in particular is the need to work. And so when you have to take on all this debt, it really is something you're deciding for your family. And the other difference that happens frequently is you have a student who has to work and do classes at the same time and pay for tuition versus a student who is in a more affluent community and has an office space to study and dedicated time. That's where these disparities begin.
Dr. Andreades?
It gives students a chance, to be able to even start to feel that a healthcare career is in their realm of possibilities, because finances and the financial burden, as again the other panelists have alluded to, really is a huge deterrent for minority students.
Good. Dr. Stone?
I mentor a lot of kids that are bright and could be physicians, but they are deterred by the cost. So if there was a way to offset the cost, we could increase the numbers.
Good. All right. Thank you, panels. Senator Cassidy.
Thank you all. Dr. Stone, my wife is a 1983 graduate of UAB.
Okay.
I kind of hide that fact in Louisiana, but that's okay. And I'll note, Dr. Galvez, you don't respect our Spanish if you're interpreting I'm telling you why you should do it. Thank you all. Dr. Stone, African Americans have as we both know, as you particularly know, much higher incidence of prostate cancer. And there's a certain kind of, cultural kind of reticence to have it addressed sometimes. I'm a gastroenterologist.
Yes.
And so, same sort of thing. And I see that you have partnered with communities of faith by which to, I assume, allay concern and spread the word. So will you comment on that?
Yeah. One of my particular concerns has been the lack of inclusion in clinical trials and the fact that most therapeutics, matter of fact, all therapeutics that are developed in the U.S. are developed based on data from white patients. And the Human Genome Project has shown that the way drugs are metabolized is different between cultural groups. So I'm concerned that the dosing, when doses are established and the FDA approves it, that it may not be appropriate for different cultural groups. So I'm trying to increase participation in clinical trials by engaging the faith-based community through which we can recruit and try to get more patients to participate because the trust bridge is already established in the church.
I'm totally with you on that. I used to do clinical research and treated a lot of hepatitis, and my population was 60% African American. I ended up being the lead recruiter for African Americans because I'd worked for 2 decades in the hospital, and there was a trust there.
Yes.
The first time they were invited in was not to participate in a trial. The first time they were invited in was to see me, and then I saw them for 10 years before speaking about a trial.
Absolutely.
So I congratulate you on that because, as we both know, it can bring great benefit.
Thank you.
To the individual and to the patient. Dr. Andrades, for some reason my R's are not rolling today. I'm so impressed with how you were kind of, what's the word, inspired to pursue healthcare and move from cosmetology into doing that environmental services work, et cetera. How do we light that same flame in others?
I think, as I said in my testimony, I think, again, it's making the financial burden on students of minority less.
Yeah, but I'm not speaking about, it has to first have that spark of interest. And the next is, how do you reduce the barrier? But the first is a spark of interest. So how do you spark that interest?
I think sitting here today is one way to spark that interest so that other minority students can see that this is a reasonable idea for them, and they can see someone that looks like them in a space where typically you don't see minorities.
So I accept that because people see a role model. My daughter's an air traffic control whatever because she saw a YouTube of a female air traffic controller. So that makes sense to me that you would do that. Okay, and then what inspired you to continue to upskill, if you will, to become that nurse practitioner? Because it's obviously a way. I went to med school with a med tech, and she had already taken all the pre-med courses. She was a med tech, and then she advanced her skills and she became an MD. So just to point that out, that works, right? So your thoughts on that?
I was inspired to continue my education to become a nurse practitioner by actually an African-American nurse, Gloria Wilson, who worked with me at Mason Square. She was in her 60s at the time, and she was going to school for her master's degree. And she kept kind of saying, but you can do it. Like, you can do it. And I just said, okay, well, I'll apply. If I get in, then I'll continue my education. So my inspiration to continue was this African-American nurse who is in her 60s and still searching and looking for opportunities to grow in education. A role model and a mentor. Again, a role model, yes.
Dr. Galvez, you had mentioned increasing the Latino workforce by having some sort of, federal funding tie that would require someone to have a second language in order to advance. But frankly, that would discriminate against, like, African Americans or against others who might, Native American, who may not have a second language. And so square that circle for me. It seems like we're creating another barrier to require a second language.
It's a great question, and thank you so much for it. It really is, as I mentioned as well in my testimony, language has frequently been ignored. And yes, it's challenging. I didn't want to, my parents forced me to speak Spanish at home. That's how I learned it. And yes, I'm privileged that I was able to learn it at home, and very grateful because it's my superpower, like I mentioned. But it is something that I believe should be encouraged, especially if you have a medical school that, for example, in California, by 2050, it's going to be almost 50% Latino. And so those considerations of language will improve efficiency in your clinic, right? If you have a 15-minute visit...
I accept that. We're almost out of time.
Oh, sorry.
We are. But maybe as a question for the record, we have to see that we don't create other barriers for a future Dr. Cook. And let me just finish by saying this. As a physician, I thank you all for still seeing patients. So thank you. I yield.
Senator Casey.
Let me start by thanking you, Mr. Chairman, and the ranking member for having a hearing on this range of critically important issues, whether it's diversity of the workforce or whether it's health disparities or maternal health or maternal mortality. And I believe that in order to nurture a future generation of black and brown healthcare workers, or in order to close gaps between outcomes for white and black mothers, we have to start in childhood. And that means that the Congress of the United States has to get into the game in a way that we haven't ever really. I believe it comes down to at least 5 basic freedoms that every child should have a right to enjoy. And we should invest in those freedoms, not just talk about them like they're platitudes. The freedom to be healthy, the freedom to learn, the freedom to have economic security, which means giving children the opportunity, their families the opportunity to save at a very young age for their future. The 4th freedom would be the freedom from hunger, and the 5th freedom would be the freedom to be safe from harm. If every child has those 5, health, the opportunity to learn, economic security, freedom from hunger, and to be safe, we will have a much different outcome on all these issues we're here to talk about. But the federal government hasn't done that. And so I think it requires a maximum commitment to our children. I'll start with Dr. Lawson. You had talked about the improved outcomes patients have when they're able to see healthcare providers that look like them, a very important point to make in this hearing and beyond. In the context of maternity care, what has your experience been with both midwives and doulas, and what role can they play in reducing health disparities?
Absolutely. Thank you, Senator. I've had a 22-year history or experience in OBGYN. My entire career, I've worked with midwives and doulas. I even owned a birth center myself and employed midwives. Very impactful. Number one, I believe women should have a choice with what type of provider they want, and that's what midwives can do. I think that doulas are an excellent support for women. They were an extension of me. I could send the doula to the house, help a woman in early labor, postpartum checks, mood disorders. Sometimes they would share things with the doula they may not want to share with me. So very important aspect, an add-on support for women during pregnancy and childbirth.
Well, thank you. We're all trying to do more to invest in programs that would support doulas and midwives. Dr. Galvez, you mentioned the role of community colleges in helping to develop the pipeline of healthcare workers and for diversifying the workforce. Community colleges are the most diverse sector of higher education. I know that just from representing Pennsylvania. We've got 15 community colleges, and I'm amazed at the sophistication of the curriculum and how well prepared young people are coming out of those community colleges. How can we better use the opportunities that community colleges offer to help grow and diversify the healthcare workforce?
It really was, at least for me, I didn't know how to study. I did poorly in high school. It wasn't until community college that I learned how to study. And I learned those I used those skills at Stanford for medical school, those same study skills. And so I do think, as mentioned, I think it's an untapped resource. I think recruiting early and encouraging students to consider a career in medicine and other healthcare fields it's a good source. Just like you said, it's a very diverse pool. And to better use them and include them, it's to create pathway programs where we have, in California, we have the California Medical Scholars Program, which is in development, where they're linking community college. But it really is, it's providing mentorship and guiding them, but it's not guaranteed acceptance. And that's where I think taking it a step further and guaranteeing these students and creating even a quota for medical school so that they can better reflect their community is a strategy for diversifying the workforce.
Mm-hmm. Doctor, thanks very much. And before I conclude, I want to commend Dr. Cook for telling your story here today. The fact that you attended Drexel helps, in my estimation. but it's a great American story, and I know you worked hard to achieve it. So thanks for being here today and providing that testimony. Thanks, Mr. Chairman.
Thank you. Senator Marshall.
All right, thank you, Chairman. This is obviously an issue very near and dear to my heart. It's an issue that I've dedicated my life to solving. And before I go on with my remarks, I want to make sure everybody knows that one maternal death is too many. And yes, we need more minority doctors, nurses, the whole gamut, okay? I totally acknowledge that. Mr. Chairman, I would suggest that the work we've done with community health centers will do more to impact this than all the other ideas we're hearing about. That our vision of these community health centers would have prenatal clinics in them and then help take care of the woman after the baby's delivered, something as an obstetrician that maybe I didn't do the best job after we got to about 6 weeks. And the other thing that would impact this more is stopping the illegal crossings on our border and the fentanyl poisoning that's just not, it's accumulating problems for my moms as well. You know, my story, I think it's, you have to hear my story, and I'm sorry, but I'm a first-generation college student too. I went to a community college. My wife went to a community college nurse. 90% of the nurses in our hospital are community college nurses. Went to a residency program in St. Pete, Tampa. Very busy, 8 residents, 5,000 deliveries a year. So in 20,000 moms that we delivered, you know how many maternal deaths we had? It's 0. And how? So the answer is how come? 2 things. One, we had incredible committed doctors and nurses and ultrasound techs. But number 2 is I set up a prenatal clinic. When I got there, a fourth, maybe half of our moms were not getting any prenatal care. I went to a church on the wrong side of town and said, can we use your basement to set up a prenatal clinic? And made sure that every mom had prenatal care before they ever got to the hospital. And that probably, you know, how many lives that saved. But that was one simple solution. And then in my private practice, half of my moms, I delivered over 5,000 babies personally, and half of my moms drove more than 60 miles to see me. By the way, the only thing worse than no prenatal care is bad prenatal care. It scares me to death when people think that they should be delivering babies in facilities that have 1 delivery a week or 1 a month. That's a scary situation as well. But again, 0 deaths. Why? Because, and half the babies we delivered in residency were minority. Half the babies we delivered in my private practice were minorities, half of which were on Medicaid or had no money. So it wasn't like it was this perfect group of people that had everything in life. Half of my patients spoke Spanish that I delivered. So, you know, those were challenges, but no deaths. It's because we gave prenatal care, and I was obsessed with prenatal care, and my nurses were obsessed with giving good prenatal care. Ask the panel, how many women died in 2023? Maternal deaths were there in 2023? Does anybody know the answer to that? Okay, it was 684. In 2021, it was 1,205. So we dropped from 1,200 to 684. So first of all, I want to thank all the hardworking nurses and doctors and the people out there at community health centers that are making a difference. Next, what's the most common cause of maternal death now? Does the panel know that? Go ahead.
In Black women, cardiovascular disease. In Native American women and in Caucasian women, we sometimes see mental health and substance use disorders.
Yeah, I wish that was the case, but the most common cause of maternal death now is suicide and drug overdosing and fentanyl poisoning, okay? That's the #1 cause. And what percentage of these deaths occur more than a week after delivery?
Over half, around 52%.
Yeah, 52, 53%. So half of these deaths are occurring after, a week after delivery. That's why these community health centers are so important, is to follow up on the mental health aspect, let alone the addiction issues as well, okay? So that's the solution to the postpartum issues. Intrapartum, #1 causes now hemorrhage, heart disease, stroke, PE, cardiomyopathy, infection, hypertension. Those are the ones that we can impact with prenatal care and intrapartum care as well. And I think we have to also acknowledge why is heart disease spiking right now from a maternal M&M situation as well? Well, it's several reasons. One is our moms are older. Number two is they're heavier. And number three is diabetes. The amount of diabetics, type 2 diabetics that I saw in my clinic doubled or tripled in my 25-year career. So again, we go back to our community health centers with nutrition as a component, with mental health as a component, that we hopefully have healthier moms before they get pregnant. That's what's going to impact all these. We don't need to form committees and pray about it. We know the solutions. I think our community health center is the best thing I see out there that's going to touch all people, and just look forward to continuing the great work the chairman and ranking member have done in these issues. So thank you so much. I yield back.
Let me just inject what Senator Marshall was talking about. Get that legislation moving again. Senator Kane.
Thank you, Chair Sanders, and thanks to the panel. What a great panel. So you all in your professional lives have some pinnacle days that really make it worth doing. And I just wanted to reflect, as I think about the work we do here, we may not have as many as you, but we have some. And 3 times in the 11 years I've been here, we've passed meaningful legislation or taken meaningful action on the floor of the Senate by 1 vote. And on those days, it makes me think, wow, what if I hadn't run? In August of 2017, we saved the Affordable Care Act in the United States Senate by 1 vote. And 30 million people did not lose health insurance. And tens of millions of people did not lose the ability to be protected against discrimination because they had a pre-existing condition. In 2022, we passed the Inflation Reduction Act by 1 vote, capping prescription drug prices, out-of-pocket costs, negotiating for prescription drugs under Medicare, passed it by 1 vote. The third 1 voter is not generally thought of as a health bill. It's the American Rescue Plan in March of 2021. But it had within it something really important. Prior to the American Rescue Plan, Medicaid would cover a mom after birth for 60 days. In the American Rescue Plan and then subsequently in appropriations bills, we extended at option. States could choose that a mom would be covered post-delivery for a year by Medicaid. It's interesting, it was a state option, but it was enormously popular. 46 states have embraced this option. 3 are in the process of embracing it, and only 1 has not pursued it. What is this likely to mean playing out over time? That Medicaid will now cover moms, not just the kids, but will cover moms for a year after delivery. Please, Dr. Lawson.
Sure, thank you. Thank you for that comment, and I appreciate your work. The one state that has not adopted legislation is Arkansas, and that's originally where I'm from, where over 50% of moms here are on Medicaid that deliver. So this has huge impacts, and I extend to you that it is beyond even maternal care. When you look at the 5 top causes of infant mortality in this country, 2 of those 5 are due to either maternal complications or low birth weight babies, really due to preterm birth. So you're talking about lifelong and impact, because we know that infant health also is an important marker of the overall health of society. So when you talk about how impactful this is, major impactful, again, I'm in Texas, we're excited. I remember, and certain my colleagues that have done OB-GYN as a rotation, even as a student, know that we would try to compact all of a woman's health care in those 6 weeks where she had Medicaid coverage. So we thank you for the work that you all have done for this.
Yeah, the ability not to have to cram it into 6 weeks, but to have it for a year. I mean, I think we'll start seeing statistics, and I would suspect the statistics, because of who Medicaid covers, are not just likely to be a reduction in maternal mortality, but it should the disparities that we're seeing in maternal mortality. And so I'm really interested in following this It's still relatively recently implemented. I think Virginia might have been the first state that embraced it. We happened to have a doctor as governor when this got passed, the American Rescue Plan, so he was fast out of the starting gate. But the fact that now every state has either done it or in the process of doing it, save one, we seldom do things that are so popular here, where states say, we want to be part of this, and I'm excited that we are. I want to just, my colleague, Senator Casey, asked the question about community colleges, and I don't need to go into it as much, but I mean, it's interesting to note that of our 5 panel, I think both Dr. Galvez and Dr. Andrade began in community college, and it's really important. Community college student, just who is a community college student? The average community college student is older than 25, receives a Pell Grant, attends part-time, and is a woman, and is more likely than the population norm to be a person of color. That's our community college population. So many fantastic healthcare professionals start there, and we just need to do more really to recognize our community colleges as great beginning places, accelerators, on-ramps, right? On-ramps to success in many ways, but including in healthcare professions. And so I think it's just interesting in the randomness of who are our 5 witnesses. You know, we have 2 who began in community college, and I appreciate that. The last thing I'll say, it's not really a question, but we have to get a hold of it. We've been using a set of maternal mortality statistics to compare to other nations and also to look at disparities. And there's been some recent churn about whether the statistics that we've been using are accurate. And I'm kind of a data geek, and I really hope that we can work together with the CDC to arrest any confusion about the statistics. I think measured accurately, we're still going to find we're an outlier with other nations, and we're still going to find these significant disparities. But to the extent there's been a little bit of controversy about them, I hope we can work together to improve the data and how we report it. Thank you, Mr. Chair.
Senator Braun.
Thank you, Mr. Chairman. In my home state of Indiana, we have the 3rd highest maternal mortality rate at 44 deaths per 100,000 births, 22. That's sad. Regarding this sad state of affairs, local news article said that nothing has changed in 10 years. That needs to change. That lack of improvement is disappointing state by state. That's why I've been vocal on healthcare in general here. And we did pass out of this committee the PREMIE Act reauthorization, which renews resources for HHS to promote healthy pregnancies. The Improving Access to Maternal Health for Military and Dependent Moms Act, that is being reviewed. Hopefully we get that through this committee. And the Standing with Moms Act, which would increase the availability of pregnancy-related resources to expectant mothers, another bill. So we're drawing attention to it. My question is for Dr. Lawson. In your home state of Texas, what have you seen there? Have they been improving? There's a lot more agility at the state level to address things. Tell me what's been happening there.
Thank you for the question. Up until 2021, we have not improved some new data. I know that our MMRC is working on the biennial report. We'll hopefully have that this summer to see where we are for 2022 and thus far. But overall in Texas, you know, Texas has one of the worst rates of maternal morbidity and mortality. We are very excited that the postpartum Medicaid extension was made, but of course we are a state that does not have Medicaid expansion. What we're also concerned about from a workforce perspective is having enough physicians, right, for the population, and enough physicians to actually
that are doing a good job? Do you keep track of that? Because you'd think among 50 that someone
I can point to California, the California Perinatal Quality Collaborative. They've done some really great work, and especially when you think about that population. Also, New York is doing some really great work. I think, again, in collaboration with the MMRCs, the data piece is very important. That drives a lot of policy from a public health perspective and for hospitals.
more doctors and professionals paying attention to it, especially among minorities as well. We should be throwing everything in the kitchen sink at this, both federally and by state. I want to segue to one other issue that I bring up always, is the broken nature of our healthcare system that's increasingly being run by large corporate entities that I don't know that have any interest in prevention and wellness, mostly in expensive remediation. And until we get that fixed, we're going to keep, I think, avoiding what we all know makes more sense, prevention and wellness. And that's going to take a cultural change within healthcare itself. Probably the biggest thing would be, how do you lower costs among insurance companies and hospitals? I can tell you what's been happening has been the opposite. It's alienated even a lot of physicians and nurses from getting into the business, because their dream wasn't to be working for huge corporations that don't have practitioners in mind and the patient. That's got to change in terms of what we can do state by state and here as well. Senator Sanders and I introduced a bill, and it's already got a lot of bipartisan support. Senator Smith, Hickenlooper, Grassley, Coons, Hassan, Ernst, and Baldwin. And this would be transformational. It's a bill that's going to force corporate healthcare to accept transparency and competition, not to have barriers to entry for people to get into the healthcare business or try to corner the market with high costs along the way. So I would urge all of you to make sure in a grassroots way you get behind it, and until we break that grip to where that is in control, we're never going to address this or many other issues related to healthcare. Thank you for being here today.
Well, let me just thank Senator Braun for his work, and to mention to him this whole issue of corporate private equity control over our healthcare system is exploding. You're right. Young doctors don't want to be corporate employees. It's an issue we will deal with. Senator Hickenlooper.
Thank you, Mr. Chair, and thank all of you for being here, but also for your service. Could all be making more money doing other things, and appreciate your commitment. I'm from Colorado, and we've been working a lot on apprenticeships. And I think on a broader scale, they can help address the shortage of minority healthcare professionals. Colorado Public Health Works is one of the first of its kind. It connects AmeriCorps volunteers with a registered apprenticeship program run by a Trailhead Institute. Their goal is to recruit a more diverse workforce. It allows the apprentices to get valuable on-the-job apprenticeship experience while we make progress in our public health needs. So I'll start with Dr. Galvez and Dr. Andrades. How are apprenticeship models and other on-the-job training models particularly helpful in terms of the recruitment and retention of diverse healthcare forces? And then follow that up with additional federal support for apprenticeship programs, which we've worked on this committee. Would that be helpful also in terms of recruiting students of color?
Thank you for that question, Senator. The apprenticeship model is fantastic, and I think of it from the medical side. We frequently shadow, and shadowing a physician is where you learn what you potentially could be, what you're getting into, right? And so there's some shadowing experiences that aren't great, like at an ER where you're passing out juice and blankets. That's not really learning about what the ER functions. But when you're in an ER where you're taking care of patients or helping to translate and seeing what a physician is doing, that buy-in, that spark that was mentioned, that's what really gets people hooked, right? That they want to proceed and go into that model. And so I think that's a good format, and it likely would reduce attrition, because there are, like, an example is you have someone who goes to an Ivy League school, right? They want to be a doctor, and yes, they'll get some research experience, but yes, they'll shadow in a clinical setting, but you see a high attrition rate in people entering medicine who didn't really get a great initial experience. And so apprenticeships, I think, are a fantastic model.
Dr. Andrade?
I also believe that apprenticeship model is probably the best way to help minority students. As I mentioned in my testimony, BSEP, the Bay State Springfield Educational Partnership, is really a mentorship program between the City of Springfield Public Schools and Bay State Medical Center to provide underserved students with the opportunity to work alongside different healthcare professionals. And I think one of the major benefits there is that, maybe a student may go into it saying, well, I want to be a radiology tech, or I may want to be a nurse. But students have followed me, and I work very closely with surgical residents and surgeons, and maybe that exposure to another level in the healthcare field is integral in them making the decision, okay, I don't just have to be, let's say, I don't have to be this position. I can be the surgeon. I can be, the nurse practitioner. And again, that program really offers them an opportunity that they wouldn't have otherwise.
Right. Thank you. I appreciate that. And Dr. Braun and I have worked on, Senator Braun and I have worked on this and have a lot of support on the committee. We're making progress. Dr. Lawson, as you noted in your testimony, CDC reports that black women are tragically 2, 3, 4 times more likely to die. And as we've also just heard, a lot of that's due to mental health issues. Colorado has a 2023 maternal mortality report based on 4 years, 2016 to 2020, that found that basically a third of all deaths were attributed to suicide or accidental overdose, which is staggering. What do you think how do we best address this mental health substance use disorder epidemic that we have?
So that brings up one of our focus areas as an organization. There are certain specialties we're worried about, the workforce and availability. I've not been to one state during my presidency during this past term where they are not have a shortage of behavioral health care providers. I myself practice in Dallas. I'm not in Podunk, but we still don't have an availability of behavioral health care providers. So there needs to be investments on how we can give scholarships for those students, medical students, to get them interested in that career. Secondly, thinking about psychologists and other specialties, right, that support those services. And also when you think about women, about 55% of women, even if they had Medicaid, there's a coverage gap. So we got to also think about coverage. Many of my psychiatry colleagues do not accept commercial insurance because of low reimbursement. So really the root cause of this is reimbursement for behavioral health care services and showing value in that.
Great. Thank you all. I'm out of time. I'll yield back to the chair. Thank you.
Senator Marshall, did you want to say a word?
Well, I just want to again thank all of our witnesses for coming. Thank you for your dedication to the health of women and pregnancies and deliveries and all the other aspects of health care. Thank you so much.
I just want to echo Senator Marshall. Thank you all. This is, without exception, excellent testimony. And we look forward to continue to work with you to implement many of the very important suggestions that you made. So thank you all. And with that, let me just say that the hearing is over. For any senators who wish to ask additional questions for the record will be due in 10 business days, May 16th at 5 p.m. Finally, I ask unanimous consent to enter into the record 12 statements from stakeholder groups. The committee stands adjourned.